Hello, everyone. Good morning. My name is Martina. I'm moderating this session, and I would like to welcome you, and especially Bruno, for the next talk. I'll be with you with the mic for questions at the end, but for now, the floor is up for Bruno.
Thank you. Welcome, everyone, to perhaps the session with the longest title ever. I guess we're trying to test what the character limits were. Apparently, it's not 166. I'm here today to talk about the prior authorization process and from a more technical perspective, going beyond some of the diagrams we've seen throughout the conference, and explore ways of how to make it as fast as it can be. My name is Bruno Neves. I'm an integration specialist with Salesforce. I work primarily with the integration part of the business we call MuleSoft. I've been an integration specialist for the past 15 years or so, working with healthcare industry for most of that time. This is my fourth Fire DevDays. I love this event. I try to come every year. I think this is the best opportunity to learn and stay up to date with everything that's happening within interoperability. So that's my contact information. Feel free to reach out to me to talk about this or whatever. So prior authorization, prior auth, pre-auth, PA, it's all the same, right? If you're here, chances are you already know what PA is, but hopefully you've never have to personally experience it, because I think nobody deserves that. So today I'll give you a summary of what PA is and what the common challenges are, some of the whys. Then we'll talk about what the industry is doing to standardize this process and with that accelerate PAs. I'll do a quick run through of the process end to end, leveraging implementation guides from the Da Vinci work group. Thank you. And then finally, a briefing on what potentially can be next, what else the industry can be doing to streamline the process even further. Is it okay if I assume that you all understand prior auth, right? I think it's a good, except that guy. Okay, good. So I still need to summarize, though, why it exists, because there is a lot of debate in this topic. I don't really want to get into. But in summary, it's all to balance the accounts, right? So imagine if all the treatments, procedures, tests, devices, they were all approved, no questions asked. The math wouldn't really add up. There's no question about that. So as you know, healthcare is not the most affordable thing in the world. So the PA process was created exactly to help with, these accounts. The problem with the PA process, though, is that it has its challenges too, right? I don't think I need to go into too much detail in this slide, but the key takeaway here is that prior authorization is many times a very painful process, literally sometimes, right? It's often not a real-time process, which further extends the wait for the patient and, to get what they need, whether it's a, medication, a device that's going to help the patient feel better. So it's typical that PA requests take days or weeks for the patients or providers to traverse through this process end to end. And guess who is suffering in this situation? So we, as a community, need to improve it. So now, how do we do it? Well, the Da Vinci work group did this amazing work to standardize the prior authorization process. They created a series of implementation guides that standardize how the providers can directly interface with the payers during the PA dance, right? So there are 3 steps there, primarily. The CRD step stands for Coverage Requirements Discovery. It lets the provider know whether PA is required for a particular procedure, treatment, device. And if PA is required, what is going to be the information needed to substantiate the patient's case? DTR stands for Documentation, Templates, and Rules. It provides a mechanism for payers to express their documentation requirements in a way that a computer program can take action on. So which allows the provider system to perhaps autofill data that's necessary to support a prior authorization request. And finally, PASS, which stands for Prior Authorization Support, which provides that mechanism that's gonna, allows the providers to directly submit the PA request to a payer. So let's say it in action. Let's wear our clinician hat here and start with the EHR UI. Here, we can perform a patient search. We'll find a patient and indicate that this patient needs a glucose monitor. So it's there. I'll be showing the transactions as it passes through the wire all the way to the back end. So what happens next, right? The EHR will need to send the request to a CDS service that is typically hosted by the payer, or perhaps an organization that's supporting this process for the payer. This is what the CRD request will look like in the wire. So as you can see, this is leveraging the CDS hooks framework, and a number of FHIR resources are composing this FHIR bundle, including, of course, the device that's being requested by the clinician and the patient. So that's that. Then when the CDS hooks request reach the back-end implementation of the CDS service, it will perform a number of functions, business functions, based on the patient's plan, some healthcare rules, location rules, perhaps gold carding, hopefully one day, all to determine that whether a PA is really required in this case or not. And upon the analysis performed by this CDS service, well, in this case, it's determined that a pre-auth request is required and that some additional documentations will be needed. So among many details that this CDS card returns, it will include a system action, which is going to be processed by the EHR system so that a user of the EHR system can take action on at a different time later on, perhaps the back office staff. Now, when the CDS card is delivered to the EHR system as part of the response of that CDS hook call, the EHR is going to render the information so the clinician has the opportunity to explain to the patient how this process works and what the outcomes can be. Should the clinician and the patient decide to move forward with the PA, either the clinician or, like I said, the back office staff can later on proceed with the next step of the process. And that's pretty much concludes the first part of the process. And I think it's all good so far. PA required, yes, no, that's what we're trying to do so far. Now, transitioning to the DTR step, the documentation, templates, and rules, we'll take advantage of the response we just received from the CDS service. So let's go ahead and request a glucose monitor for the patient. And from here, we can launch a Smart on Fire app with a specific context. This context will retrieve the questionnaire for a particular device the patient needs, plus all the IDs for the resources that are involved in this transaction. So typical IDs for the patient, the practitioner, the insurance coverage would all be there. The next step is that the backend portion of the Smart on Fire app needs to make sense of this context and retrieve the associated data from the EHR with a series of Fire resource calls or even executing CQL statements. In this case, we're just calling back to the HR to retrieve all the answers for the questions present in the device request questionnaire. But then once the Smart app has retrieved all the data it needs, and this is a process that's happening in the background, it will then render the front-end questionnaire so the clinician or perhaps their staff can review the data and, if necessary, make the appropriate corrections, override So we give that opportunity to the staff. And this pretty much concludes the DTR step. Again, to summarize, this step is all about automating the process of organizing and packaging all the data that's needed to support that PA request. Okay? Now we are off to the last step, which is sending the package created by the DTR, like that Smart on Fire app, to the payer. And this step is called prior authorization support. So behind the scenes, the Smart on Fire app produced a Fire bundle containing all the evidence, the documentation, the information that will help substantiate the patient's case. This Fire bundle will contain resources such as the claims, the questionnaire response, the device request, organization, patient, practitioner, coverage, conditions. You know, in short, it's gonna include everything that's required by that questionnaire or the CQL rules that we could have processed as part of the DTR step. Next, what happens is that this Fire bundle is sent to the payer. Now, here's a quick call out though. The prior auth requests have been historically governed by HIPAA, which in US, which requires that the PA needs to travel in the X12 278 format. However, right now there is an active statement of enforcement discretion saying that if both the provider and the payer are capable of handling the whole process using Fire, the requirement to translate this Fire bundle to an X12 278 transaction, it can be skipped. So, however, if the payer still requires this 278, the PAS service is the piece that's going to be making that translation for them. So there's the X12 translation for your reference, and at this point, the payer has the request and is analyzing it. Should the payer request is approved by, the PA request is approved by the payer, the provider is going to get a Fire bundle back containing a claim response. And since it's approved, the disposition is going to be equal to granted. Then finally, the front end renders the bundle as an approved PA. Here, note that, however, in many cases, final determination is not really going to be in real time. And for these pending requests, the provider can then subscribe to the updates. And as soon as a final determination is reached by the payer, the provider will know about it through this subscription. So what we've discussed here today are the interactions between the provider and the payer. And like I said, the Da Vinci work group did a truly phenomenal job streamlining this conversation. But what else can we do here to support this process even further? Well, the reality is that each payer will have their own internal PA review process, which is another step in the end-to-end process that can delay authorizations. Payers should be evaluating how they are going to be making the pay process more efficient, and that's going to be through fixing the internal processes as well, right? So there are going to be, we heard of many different technologies in this conference that are out there that could be used to help with that approach. There are process automation tools, workflow tools, Gen AI, of course, that could be used to aid some of this process. RPA, all these can be used in combination to augment the overall process. And I think there are a lot of opportunities here for both the providers, the payers to improve the process. And I think overall, with all the recent advancements in the standards and the work that the work groups are doing, I think we are trending in the right direction. Now, to build this, of course, I use the implementation guides. Not really me personally, but the Salesforce used the implementation guides from the DaVinci work group. And we also developed the CDS service, that Smart on Fire app, and the PASS service. And they are all available to our subscribers without any additional charges. I think even if you want to just explore them, you can also just go to this website. You can download the presentation. That's a link you can click, or you can just use the QR code. You can download the Studio IDE and all the assets that we developed that are going to be linked in this step. That's my presentation. Any questions from the audience?
I would be interested to know more details about the kind of security arrangements between the payer and provider. Is there a single sign-on, or is that documented somewhere, or is there more? I'd be interested in more information about that.
Okay. Yeah, and there's going to be, from the implementation perspective, there's going to be different touch points. So starting with the CRD step, when the provider is checking with the payer whether a PA is required or not, that's going to be an API. So it's fair to expect that the traditional methods to secure an API will be in place. So the payer is going to enforce authentication and authorization rules. So it's expected that the provider, that the payer knows the provider beforehand, issues credentials, information, ID, and secret, and whatever else they need to secure that endpoint. So that's going to be the first point. From the DTR perspective, it's a Smart on Fire app that's really running on the provider setting, right? So it's expected that it's going to be leveraging the Smart framework to do that security dance with the HR system. And then for the final piece, the PASS piece, it's going to be similar to CRD, right? Because that's another API that the payer will be hosting. So
somebody has to trust somebody else.
Absolutely, yeah. They have to know each other beforehand for this to take place. That's my view, at least. That I don't see any other way of accomplishing this.
I can just add a little bit more commentary on that. More than likely what will happen is it's a typical API to API integration. So your certificate exchange will be happening, and API keys will be exchanged. And obviously between the payer and the provider, there, besides the technical integration, some sort of agreement also will be there saying that, because there is no explicit consent or anything else at the FHIR level. So this is more at the infrastructure level, like a typical API to API integration between the payer and the provider. Within the provider side, for the others, like what Bruno said, they will be applicable in the EHR system. At least I haven't seen it.
Yeah, it's not.
Any other questions for Bruno? I think it's time for lunch.
Yes.
Thank you.
Thank you.